for offering for our Wayne State University students. My name is Jessica Bada, and I am the Vice President of Club Med Virtual. I will be leading today's session, reading any comments posted in the chat and facilitating the conversation as we go along. Before we start, I want to remind everyone to just maintain proper etiquette and please keep themselves on mute unless Noraan specifies otherwise. If you have any questions, you can post them in the chat and we will address them as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance, and will close 30 minutes after the session terminates. Please stay on the call for at least 5 minutes after the session is over to ensure that the survey is working for you. And the session will also be posted on YouTube in case you're unable to attend or want to revisit certain topics Noraan discusses today, but you cannot receive attendance hours if you are not present in this call and complete the survey. Noraan, you can start whenever.
All right, hi guys. So my name is Noraan Hassan. I am a second-year Doctor of Physical Therapy student at Oakland University. I also did my undergrad at Oakland University where I received a bachelor's in health sciences. I followed a pre-physical therapy track that was able to encompass all of the prerequisites. And I'll talk about the application and the prerequisites a little bit later. I'm also a technician at a outpatient physical therapy clinic, and I will talk about that as well. So first I wanted to start off by just discussing what physical therapists do. And the biggest thing that really we have to differentiate is the difference between a medical diagnosis and a physical therapy diagnosis. So when a patient comes into our clinic, they will have a script that will say something from the doctor like low back pain or osteoarthritis or something that is technically a medical diagnosis. And under that, the physical therapist has to come up with these impairments that this medical diagnosis has created in this patient's life and how we can modify them and how we can help them. And these impairments will fall under these 4 categories. It'll either be pain, weakness, stiffness, or laxity. If something is unstable, it can dislocate and it could cause pain. So we have to work on all 4 of these impairments. And our treatments will include things such as manual massage, stretching, stuff like that, as well as therapeutic exercise that we can prescribe them to do in the clinic, or we can give it as a home exercise program, which is great so they can take it on and do it on their own and be able to get quicker results. We also use a lot of modalities like ice, heat, ultrasound, and electrical stimulation, which I will talk about in the case study. It's pretty cool. And we also have to work a lot with patient education and biomechanical corrections. So people that have active lifestyles or even just sit at a desk all day, having correct posture and having correct muscle engagement is really important for preventing injuries. So we'll see a ton of young people, students that come into our clinic and they'll have neck pain. And I'm sure all of you guys know, you'll sit there for hours on end and you're just sitting over your desk and you're hunched over, and things like that can really create problems and they can cause neck pain, back pain, and a lot of issues. And correcting those biomechanically and giving correct patient education on posture is really important for preventing injuries. And so the ultimate goal of physical therapy is always to restore or increase function. We want them to be able to be as independent as they can in their lives and be able to function without pain and without difficulty. So the cool thing about physical therapy is there are a ton of subfields. And once you graduate from a doctorate program, you are licensed to work in the vast majority of them. Some of them do require more certifications like women's health and vestibular rehab, but a lot of these fit under the general doctorate. So the most common one that you guys will see as you're driving just about anywhere, all the ATIs, the health quests, the team rehabs, all of those are outpatient orthopedic clinics. So we will see a lot of people post-surgery, post-injury, or just from wear and tear, back pain, things that just happen as life progresses and as you get older. And so we'll see a lot of patients like that in this setting. And that is in contrast to acute care or inpatient rehab, which happens in hospitals. So it'll be for patients that are in there long-term. If they had surgery and they are immediately being rehabbed afterwards, it'll be in that setting. There's also the pediatric setting, which is quite different than the outpatient setting. It's probably the biggest shift just because of the patient population. You're working with a lot of children, which means the vast majority of your patients are going to be dealing with neurological or developmental deficits. So you'll see a lot of cerebral palsy, muscular dystrophies, things that you can't necessarily heal or correct, but you can slow down the progression of, and you can help them lead like a more independent and more functional life. There's also cardiopulmonary, which is pretty cool, and it's working on their cardiac and their lung capacity and their health. A lot of people with COPD will be treated under this. There's neurological clinics where you work with patients after a stroke, after traumatic brain injuries, spinal cord injuries, MS, a lot of stuff like that. And it's pretty cool because with stroke and traumatic brain injury specifically, you'll also have to deal with a lot of cognitive deficits that could occur after the injury or the onset of the stroke. And so you get to work with the cognitive as well as the physical, which is really interesting. And then there's the geriatric, where you're working with older populations. You can get a lot of Parkinson's, a lot of Huntington's, stuff like that. There's sports medicine, vestibular rehab, which is pretty cool for people that have vertigo, and that does require some more training that you don't necessarily get in just the doctorate. And also women's health, where you deal with a lot of pelvic floor issues. And again, this one does require additional training because it is very specialized. And you'll work with a lot of women post-labor or while they're pregnant. Sorry, I had to change my microphone. So in order to become a physical therapist, you do have to complete a bachelor's degree, and it could be in anything, but there are required prerequisites for whatever program you are applying to. So it's important to research the program, make sure that you cover the things that is required. And then you complete an application through PTCAS, which is a wonderful program that makes it so you can apply to just about any school in the country with just one application, and then you're able to do the supplemental applications for each school. And through PTCAS, you upload your transcript, your letters of recommendation, your personal statement, and then that's where you can log in your patient care hours, volunteer hours, and shadowing. And then after your application, you would hopefully get admitted into an accredited university. So universities every couple of years have to get accredited by the CAPT here. And so they will actually go on campus and run through the entire curriculum from top to bottom, go through the facility and speak to all the professors and decide how long they're going to accredit the university. The top they can accredit is 10 years at a time. If they feel like the school isn't necessarily up to that level, they can give a smaller amount of years. So Oakland University actually was accredited for 10 years, and those 10 years were up this past summer, I believe. So they had to get reaccredited. And then after you graduate, you have to take a board exam, the National Physical Therapy exam. And once you pass that, you're licensed in the state that you took the exam. So getting accepted into a physical therapy program is quite difficult. It is getting increasingly more competitive. And like I said, you can get your bachelor's in just about any major as long as you get the prerequisites in there. And you want to choose the most logical route because you don't want to have to take all of the classes for your major as well as a ton of prerequisites. So if you research the prerequisites for whatever programs that you have your heart set towards, you can kind of implement it into the most logical route and choose the major that fits. So Oakland University had a really great program where they do, it's called pre-physical therapy. And I think Wayne State has it as well, where they fit in those prerequisites as much as they can, so you don't have to take so many things outside of your major. Like I said, it's really competitive, so having a high GPA will of course help. Most programs take an average of 50 students. Oakland University takes only 38. So I'm in pretty small class. I know University of Michigan Flint takes 60 students, so some of them are bigger, but it's generally still a pretty small cohort, so it's very competitive to get in. You do have to take the GRE, and you fill out the PTCAS application, and then with the supplemental essays that you have to write for each program that you chose, you would be good to go with the application process. And some schools offer interviews. Wayne State does require interviews. Oakland University does not, so it just depends on the program. So since I work in an outpatient clinic, this is what I see the most. So the case I kind of wanted to discuss today is surrounding an ACL tear, because it is a very common injury. So we have an 18-year-old female basketball player who injured her ACL during a game. She has no previous injuries to the knee, but an MRI imaging confirms that she tore her ACL. So after it was confirmed, she had an ACL graft surgery, and she was sent to an outpatient physical therapy clinic so that we can evaluate and treat her so she can return to her full sport. So running through this, I'm actually going to cover quite a few things leading up to the injury, so things that we might not see in the clinic. So this is going to include the risk factors, how an ACL gets torn, how it's diagnosed, and then the progression of the physical therapy treatment. So what's an ACL? It's the anterior cruciate ligament, and it's in your knee. In each knee you have one, and you can see it in that first picture on the left. It's the one in the very front. And what this ligament does is the biggest job is it limits the forward motion of your shin on your thigh bone. And so anything that brings your shin too forward on your thigh bone is going to cause it to tear. So it could be through hyperextension, or through that picture on the right is a very common way to tear it, and it's through rotation. So as you'll see in that picture, the woman has her foot planted. So her shin is facing one direction, but her thigh is turning in another direction as she's turning her body. So her thigh and her shin are rotating in two opposite directions, and that could cause the ACL to tear. So at the bottom there, we have a really cool MRI here. On the left is an intact ACL. So you can see the fibers are running very parallel, that dark line. Looks super smooth, everything's great. And then on the right, it's ruptured. So you can kind of see just a big mass of tissue right where the ACL should be between the tibia and the femur. So the risk factors are pretty important to understand when it comes to patient education and prevention of ACL tears. So having these in mind, you can kind of imagine the patient that would come into your clinic, and if you see them before an injury, you can educate them on how to avoid the injury. So females are actually more likely to tear their ACL. There's research that says they're 2 times as likely, and there's some research that says they're up to 10 times more likely. But all research can pretty much agree that females are more likely to tear their ACLs, and it's because of their body composite. The ACL in women is actually smaller in its length and in its thickness and volume, so it's not as strong and not as sturdy as men's. It is also more lax because of the hormones that women have that men might not have, as well as their quad dominance. So if you think about a woman, it is most likely, not always, but most likely their front of their thighs is a lot bulkier in muscle mass than the back of their thighs. So their quads are a lot stronger than their hamstrings. And if you think about what the quad does, when you straighten out your leg, it brings the shin forward on the femur. So if your quad is really strong and it's constantly pulling the shin forward, and it's not matched by the hamstrings, which pulls the shin backwards, you're just getting a constant forward motion of your shin, which is going to ultimately could lead to an ACL tear. Being 18 to 45 causes higher chances of ACL tears because they are just more likely to be active. So if you think about our patient, she was an 18-year-old female and she plays sports, so she is like the ideal patient that would tear an ACL. Another thing to think about is their body shape. Being knock-kneed is going to increase the chances of tearing your ACL. And this is a pretty cool part of physical therapy, in my opinion, because this is where you get to think about how one thing affects another thing. So why is this patient knock-kneed? If they walk in and you know they're an athlete, you can definitely start educating them on how to prevent the ACL, but is their leg shape something that we can modify? So it could be just the shape of their joints, it could be just the shape of their bones, which you might not be able to modify, but it could be due to something like glute weakness or flat feet. So if you think about flat feet, the arches of your feet, and when they collapse inwards, everything above it will also collapse inwards. So the knees will come closer together, creating that knock-knee pattern, which is going to put more stress on the ACL, increasing the chances of tearing. So the mechanism of injury essentially just means, how do we tear an ACL? So like I said before, rotation is the big one. And another thing is valgus force. Valgus force is when there's an outside force coming in on the knee. So it's essentially forcing the knee into what looks like a knock-kneed type of shape. So it could be another person, it could be a collision and an injury that causes that force that could lead to an ACL tear. However, because rotation is another common way to do it, it is also very common to injure ACLs in non-contact sports. So in something like basketball, like our patient, she has to make sharp turns. So if her foot is planted in one direction and she turns her body in another, that rotation could tear the ACL. Another thing to think about is how the patient lands from a jump. So if you look at the picture on the right here, the very first one where the patient is more upright, if you look at the blue arrow, that is essentially the line from their center of mass straight downwards. So center of mass is just where the center point of all of the body weight is. So if they are more upright, the center of mass is going to be further back. And the bigger the green arrow is, the more force or the more energy is going through that joint. So if the line between the center of mass and the knee joint is really long, the more force is being put on that knee. So if you look at the picture on the right, the individual is landing with their hips flexed. So their center of mass is more forward. This means that the arrow between the center of mass and their knee is a lot shorter. So landing like the person on the right is actually a lot more biomechanically beneficial for the knee. And what they found through research is that females have the tendency to land like the individual on the left. And this is because landing more upright is going to require more quad power, but landing more bent over is going to require more glute power. And like I said earlier, females have the tendency to have very strong quads and weaker hamstrings and hip extensors and glutes. So they found that women will land more upright, which will increase their chances of an ACL tear. So this is pretty cool. This is the part of PT that I really like because I'm really big on mechanics and physics. And so I find this really interesting. Some people hate it, but I think it's great. So how do we diagnose an ACL tear? Usually when we get a patient in the outpatient clinic, they've already been diagnosed and they've already had the surgery, so we don't see this that often. However, it is possible that a doctor can miss it and just send us a patient saying they injured their knee, evaluate and treat. So we do have to learn these diagnostic tests in the physical therapy program. So the one at the top is the one we use most commonly. It's called the Lockman's test. And the one at the bottom is called the anterior drawer test. So both of them are essentially doing the same thing. It is just pulling the tibia forward, pulling the shin forward so we can see if the ACL is doing its job. So because the ACL is preventing the forward motion of the shin, if it's there and if it's intact, you're not going to see any motion. But if the ACL is ruptured and it's not holding the tibia, it's going to be very easy to move that thing forward. And so once you feel the difference between an intact one and a torn ACL, it is super easy to make that diagnosis. Also, I have a professor right now who drills in our minds that after hearing the history and learning the mechanism of injury and just hearing the story, you should be 80% sure of your diagnosis. You shouldn't even have to touch them to be that sure. So you have to get really good at learning your history and learning how certain injuries happen so that you can make the most of your time. So you're not spending a ton of time doing tests and that you are confident in your diagnosis just based on what they say. And of course, an MRI will always be done before surgery just to confirm the presence of the tear. But like I said earlier, once they get to the outpatient clinic, at that point, they've most likely been diagnosed, had their surgery, and they're just coming to you to get treated and get back to their sport. It's still really important to be able to diagnose and to know the biomechanics and everything that leads up to the injury, because it's really important for patient education in terms of preventing re-injury and making sure that they know how to move forward. So what is the ACL graft? I'm just going to run through this very briefly because it's important for us to understand as PTs because we need to know what happened in order to be able to treat it. But of course, it's not really what we do. So what they will do is most likely they'll do something called an autograft, meaning they take a graft from the patient themselves. They just take it from another body part. So the top picture is the patellar tendon autograft, where they take part of the quad tendon and they just turn it into an ACL and they connect it through bone. And the other one is called a hamstring looped autograft, where they take tendons from two muscles. You can see the kind of indigo color and the turquoise color. They'll take the two tendons, loop them together to make it really strong, and then they'll put it in place. And they're both really great and strong ACL grafts, and it just depends on the surgeon and what they like to do. And this is the most important part for us to recognize about the surgeries as physical therapists, is this graph right here. So the red line is the strength of an original ACL, one that's not injured, healthy individual. And then the blue line here is the strength of the new ACL. So once they first put it in, you can see that it's way stronger than a normal ACL. However, immediately it starts weakening past the point of a normal ACL. And it's not until the 4 or 5 month mark that it starts getting stronger again. So this is really important to know because in the middle here, you're still progressing exercises. You're still making them work. You're still increasing their strength. You just have to make sure they're doing everything correctly to avoid re-injury. We also have to really keep in mind the surgeon's restrictions. They will send a patient in and they will have a sheet of paper for the physical therapist to know that this particular surgeon that did this surgery wants these precautions to be followed. So they could be in an immobilizer like the one in the picture here for up to 6 weeks. And the most common number is they will restrict knee flexion to 90 degrees. So you can actually set the limit on the immobilizer and it'll stop the patient from being able to move past a certain point. And this all completely depends on the therapist. Some therapists will use them for up to 6 weeks. Some therapists, or some surgeons can use them for up to 4 weeks. It's up to them. After the surgery, the patient will generally be weight bearing as tolerated. That means they can put as much weight on that leg as they can without any pain. And they work their way up to full weight bearing. And the entire time they're with crutches for the first several weeks, just to be able to get used to it. And it is up to the therapist to be able to explain to the patient what these weight bearing restrictions mean. And if they push it too far, it really increases the risk of re-injury. So you have to follow the restrictions based on the surgeon. Some surgeons could even have them not weight bearing for the first couple of days. Again, it depends on the surgeon and how they do the surgery. And we just follow their protocol and then we progress exercises as we see fit. And the surgeon could even provide a protocol for exercises, which you follow these general guidelines of when you can do certain activities. Closed chain, open chain, they will give you these big categories of exercises and when you can start to implement them. So this is the big thing with ACL tears is you have these young patients that oftentimes a lot of the manual work isn't very necessary. You could do some mobility of the scars, but usually they're very small scars just to avoid scar tissue. But there isn't much that the therapist does outside of strengthening and stretching. And so a lot of this is through patient education and giving them programs. And we start in the beginning and you start really small in order to get the patient to remember how to work their muscles. Because after surgery, a lot of them will have difficulty just getting the smallest muscle activations. And after that, you progress it through the different phases. So in the first phase, you'll start from day 1 to week 4. It's the maximal protection phase. So at this point, your biggest goal is patient education and telling them to rest and telling them to do things lightly so that they do not re-injure or re-tear the new ACL. Your focus here is pain control, getting them to do muscle activation, but with light isometrics. So that picture on the right at the top there, we call a quad set, where essentially their leg is out straight and they are just pushing the knee down in order to activate that quad. So they're not doing anything crazy. There's no weights, there's no bands, there's no resistance. It's just getting them to lightly activate the muscle. We do that with the hip muscles. We do that with the hamstrings as well, just to get things activating again. We also have to walk them through training with the crutches. So it is, again, up to the therapist to teach them what their weight bearing restrictions mean and how to not go overboard so they don't re-injure. And then we focus a lot on price, which is going to be protective bracing based on the surgeon's protocol, rest, ice, compression, and elevation, which is for the inflammation and any swelling that could happen after the surgery, as well as pain relief. Moving into the next phase, this is where we get to really progress exercises and you can get a lot more creative with them. And here we're in the moderate protection phase where we're still taking things pretty light. We're still really focusing on correct biomechanics and teaching the patient how to do everything correctly and be careful of their new surgery, of course. And so at this point, we want them to be able to walk correctly. So if you think about anyone walking out of a surgery, it's very normal to have kind of a funny walk. So they'll want to minimize their time on the affected leg. So if they had surgery on their left leg, they're going to get off of it really quickly, spend more time on their right leg, and try to avoid putting weight on that left. And through doing so, they're going to get a lot of things mixed up. Their hips are going to shift up and down, their pelvis is going to move, their lumbar spine could get affected. A lot of things can get out of whack. So at that point, we really have to emphasize correct walking and teaching them how to take more weight onto that leg as long as there's no pain, as long as we're not going against any protocols from the surgeon. We really have to normalize that so that they don't cause other injuries elsewhere. We also want to increase strength at this point, and here we can start implementing more closed chain movements like that picture on the right, or at the bottom there of that girl doing the lunge, we can do things that are a lot more functional. So as opposed to just sitting there and contracting the quad, we can get them to do standing exercises, standing squats. We can progress them to single leg activities as long as their strength is good enough for it and they can hold their weight on it. So it'll be on their affected leg. We can have them do a lot of balance exercises as well as strength exercises. And that Bosu ball I have on the right there, it's essentially just half of a yoga ball and the bottom of it is solid. And I have it there because it's really important to get balance back on the surgical side. If you think about a patient that has not been full weight bearing for quite some time, they're not getting a lot of sensory input from the bottom of their foot. So their leg will essentially forget how to balance. If there's nothing that's been pushing up into it to remind them that they are walking on a surface, the leg could forget. So we have to remind them how to balance, and we do it through challenging ways, such as putting them on a Bosu. And this is my personal favorite part, where you're at the end of the treatment and you can really up the exercises. They at this point should have full range of motion, which means they can bend and extend completely all the way without pain. And we can really focus on muscle strength, endurance, and power. And here's where we can really start to implement plyometrics, agility ladders, and increasing the difficulty of the balance training. But at this point, it's important to remember the graph that I showed you earlier about the dip in the strength of the ligament. So while it is still doing its job and it's still there, and you are still able to progress exercises, you have to really focus on correct biomechanics, especially with things like plyometrics. You have to teach your patients how to land correctly, how to jump correctly. So if you think about that picture, making sure they're hinging at the hips so that they're taking and absorbing some of the energy through their hips and not just putting all of the force in their knee. So stuff like that is really important. And that's why it's important for us to also understand the surgery process so that we know how it's affecting everything down the line through treatment. So this is, in my opinion, one of the coolest parts of ACL treatment. It is electrical stimulation. So we use electrical stim as a means for several things. Most commonly, you will see it for pain relief through several physical therapy settings in acute care, in outpatient care. Even people can take units home and use them for pain relief. But one really cool thing with ACL chairs is we can use them for muscle strengthening. And so this protocol is called NMES, which stands for neuromuscular electrical stimulation. And so it'll help the patient create the contraction. Coming out of surgery, especially if they take the graft from their quad tendon, their quads are going to be really weak. And if they're not full weight bearing and they're not using their leg, it's like if you had your arm casted. Once you get the cast off, that arm is much skinnier than the other. So the muscle has atrophied, the muscle has weakened, and we want to avoid that. So very early on in the process, as long as we're still within the protocol of the surgeon, we can use the electrical stimulation to elicit muscular contractions so we can avoid the muscle atrophy and increase the strength. So when we're first starting off, we will have these pads that's on this patient's thigh, and we'll connect it to a machine, and we can turn it on to a certain point where the patient feels the contraction. They will feel the electricity through the stim pad is pulling the muscle closer together, and it's making them straighten their knee out. So we could have them do a quad set, like in that picture in the top there. We'll put a towel under their knee that they're pushing into, and we'll put the stim pads on their knee or on their thigh, and we'll have them do the exercise as the electrical stimulation is on. At the very beginning, we will start with an on-off ratio of 1:5, and we will progress it to a 1:1 ratio, meaning when they're first very weak and they're first getting treatment, we'll have it on for 10 seconds. So they're doing the exercise and holding for 10 seconds, and then they will relax for 50 seconds. And we'll do that for 10 minutes, and they will move on to their normal exercises after that. As we progress through the therapy sessions, we bump that ratio to a 1:1 ratio, meaning at that point, they will hold the contraction for 10 seconds and then rest for only 10 seconds. They will keep doing that for the 10 minutes. So even though the treatment time is the same, they are doing many more reps during that. And so you'll move from 1:5 to 1:4 until you can really get that 1:1 and get them to wean off of the stim completely and be able to do the contraction by themselves. So the cool thing about this is I have two colors marked on these stim pads. So the red ones are going to be one channel, so they will do a muscle contraction by themselves, and the blue ones are another channel that will do a separate muscle contraction. So if a patient is coming in with an ACL tear, they most likely have some instability in the knee. And when that happens, specifically in females, there's something called lateral tracking, meaning as they straighten out their leg, as they extend their knee, the patella or the kneecap is going to come to the outside. And that is a very unstable position for the kneecap. It could cause dislocations, it could be very problematic. So we need to remind the body how to keep the kneecap in the midline. So what we'll do is we'll actually have the red pads contract first, and then just 2 seconds later, the blue ones will work. And so they'll all work together to make the knee extend. So the red ones on their own in those first 2 seconds will contract a certain part of the muscle that pulls the kneecap into the midline, and then they will move through the exercise. So we're able to use that lag time and that delay to set the patella in the correct biomechanical space. So this is really beneficial for ACL tears as well as just patients with knee instability. So this is a really cool treatment technique, and I do really enjoy this. And along with the exercises and home exercise programs, you're able to really progress these patients, and their recovery is always pretty great. I mean, all the ACLs that we've seen in the clinic I work in have always been able to return to their sports. And so it's really cool to see. But after their treatment is over, we do have to give them maintenance and home exercise programs. We need to teach them how to be able to take care of it on their own so they can prevent re-injury. So it'll be outside of just their training or their practice for their sport. They'll be able to do these exercises that are targeted towards them and their injury so that they don't re-injure it in the future. Biomechanical education is very important for people that had the risk factors leading up to the injury. If they're knock-kneed, what are the things that we can teach them, and what can we correct to correct their posture and take some of the stress off of the knee? Prevention therapy is also growing a lot within the physical therapy field. I haven't seen a ton of it, but I know that it is growing, and it's where parents will put their children who are still pretty young and young athletes in these programs before they're ever even injured so that they know how to avoid the injury. So obviously that's a great thing, especially if you understand the risk factors and everything leading up to an injury, how you can teach these students to avoid, or these patients to avoid it. So it's pretty cool. And that's all I had for you guys. So I can now open up for some questions.
There is some questions earlier. How many patients do you see every day?
So I work in a very busy clinic. It depends on the clinic that you're at. Some clinics will have 2 therapists. Some people will have even 1 therapist, but I work with 8 therapists. So it's a pretty big clinic, and each therapist can see up to maybe 20 patients a day. Before COVID, we were seeing more than that, but we have increased the slot time for each patient so that we don't have as many people in the clinic at once. So, I mean, I personally work with patients with every single therapist. So I will see, I don't know, I can't really put a number to it, but I'm often working with 2 or 3 patients at once for half-hour slots, and I'm working through the entire day like that.
Someone asked, what aspects about the job do you enjoy?
What aspects of the job? As a physical therapy technician, I'll speak on technician and also what I'm excited for as a physical therapist. As a technician right now, I really enjoy the patient care that I do get to get every day. When I first graduated high school, I was actually studying engineering, and then I decided to kind of do a 180 flip, and I went over to physical therapy because I love the biomechanical aspect of it. I love being able to correct exercises and see physically what I can change in one body part to affect another and to improve it. And it goes hand in hand with the biomechanical part that I love so much, along with the patient care. I think the two together just is like my happy place. And you're able to work in an outpatient clinic with children as old as, like, we've had patients that are 8 or 9 years old. We also work with 90-year-olds. So every day I will see people within that age range, which I think is just great. And it's a lot of fun. And as a PT, what I'm excited for is pretty much everything that I get to see the PTs do. It's being able to make your own diagnosis. It's not necessarily just taking the medical diagnosis and running with it. It's creating your own diagnosis and seeing what the deficits are and how you can improve them. I also get to see the therapists get really creative with exercises, come up with stuff that the patients can do at home with the things they have there that they might not necessarily, like if we have stuff in the gym that they don't have at home, we want to implement some stuff in a home exercise program. So we're able to get creative with the things they have at home already. So that's also really cool.
Someone asked, do you feel a German dance major would be a competitive major to apply with, although not in the realm of health sciences, as long as all the prereqs are done?
As long as all the prereqs are done, you can do just about anything. A dance major is, I've seen a dance major actually apply to PT school, and I worked with her as a technician. So, I mean, definitely, as long as your prerequisites are done, you can apply with just about anything.
Awesome. What kind of hands-on training do you do in school?
Hands-on training is huge for physical therapy, of course, and through COVID, they've actually kept us on campus because there's no other way to learn it. So we usually they have us switch partners every single class, and we're able to practice the manual techniques as well as the evaluations. But with COVID, obviously we have one partner and we were partnered with them through the entire semester, but we're still able to learn everything. Right now, up until this point in my education, we focused a lot on being able to examine and evaluate a patient. So a lot of it is testing. And with the upcoming semester, I'll actually move a lot more into the treatment and the manual parts of it. So I am looking forward to that for sure.
Awesome. What type of person would be best suited for this field?
Um, I would say creativity is not something that you often really think about with something that is so health field, but creativity is huge in physical therapy. You want to get your patients as interactive as you possibly can with their process. So we have therapists outside in the parking lot playing basketball with patients all the time. If we have a young athlete, we try to integrate things into their program that is going to interest them. We also, I would say, detail oriented, being able to pick up on just like little changes in the patient that could make all the difference. For example, an ACL tear that walked in with flat feet, being able to recognize that something that's not necessarily at the joint you're examining is affecting that joint. So being able to see that. And being a people person for sure. You have to be able to speak to people and make them comfortable and be comfortable speaking to other people.
Awesome. What is the most common case that you encounter?
Most common cases, so in an outpatient clinic, the most common things you're going to see are shoulders, knees, and spines. And spine could be low back or cervical, so the neck. Those are by far the most common things you'll see, and a lot of it is age related. So we'll see a lot of middle-aged people coming in, a lot of people in their late 50s and their 60s that come in with neck pain, low back pain, and stuff like that we can definitely treat. And knees, always knees.
Someone said not a question, but a comment. You seem super knowledgeable, and I appreciate your presentation.
I appreciate that. Thank you.
Someone asked, what specialty are you interested in and why?
So, walking into PT school, I was very excited about pediatrics just because I didn't know much about it and I thought that it was like a very cool field. And I haven't learned that much about it, so I am still pretty open to it. But outpatient orthopedic is proving to be more interesting the more I learn. And I'm really enjoying it, as well as neurological clinics. I didn't really think that neuro was going to be my field at all, but with the classes I'm taking, I'm finding myself more and more interested in it. And the best part is, the second I get bored of one, I'm still certified to work in another. So it's pretty cool.
Someone asked, how do clinicals work as a PT student? Also, what type of testing do PT students go through?
So how do clinicals work as a PT student? It depends on your program. So the way Oakland University runs for me is I was supposed to have my first clinical rotation this December, actually. So I'm currently a year and a half into my doctorate degree, and I was supposed to have a clinical in December, but they pushed it to next summer because of COVID. My second one was going to be in the summer, so now I'm going to have two in the summer. And then the Oakland University curriculum ends with two 12-week clinicals. So you are on clinicals for 6 months straight at two different locations, and you work under one CI. They're your clinical instructor. And in the beginning, they're very obviously cautious of you. You're still a new student. It's your first clinical if it's really early on, and they want to make sure you know what you're doing. But by the end of it, you should be completely independent, doing your own evaluations and taking care of your own patient cases. And what was the other question?
Um, how or Also, what type of testing do PT students go through?
So the testing we have to do is very different than anything I did in undergraduate. There's a lot of written exams, of course, for written information, multiple choice, as well as short answer. But the biggest difference for me has been a ton of group projects, which I did not expect going into grad school, but they are pretty helpful as much as I didn't think they would be. They ended up being very helpful and I do appreciate them. And also there's a lot of practical examinations. So you will be assigned a proctor who will be either a TA, a teacher's assistant, or the professor, and you'll get a patient case or you'll get a certain scenario or whatever it is they assign you, and you're tested on how you perform that in front on the professor, and they grade you that way. So it's a little bit nerve-wracking, but it is definitely the best way to prepare someone for a hands-on job.
Someone asked, how can we prevent these injuries?
So these injuries, so we can talk about ACL, which I just did. Since it's the case I just did, it's a lot of biomechanics and it's a lot of making sure the patient knows how to avoid stressing their joints. So if the patient already has a posture that puts a lot of joints stress on the joint or on their knee, it's how can we undo that posture, or how can we teach them to go about their daily life to minimize that kind of stress. So for example, that jumping example, teaching patients how to land when they're jumping and doing it repeatedly, because when they're in a game, they're not going to pause before they jump and think about how they're going to land. So we have to practice it enough times to where it becomes part of their muscle memory and make it so they don't have to think about how they're doing it and they end up doing it correctly. Preventing injuries that we see all the time, such as neck and low back injuries, it's all about posture. Low back, the first thing anyone's ever going to tell you is make sure your core is super strong to avoid low back injuries. It's kind of just like one big circle and all of it's connected from your abdomen to your lumbar spine. And if the core is not strong and the core is not supporting it, your lumbar can do a ton of messed up things. So you got to make sure your core is right. As a student, making sure that you're sitting up with correct posture when you're studying. I'm the first person to get super hunched over. And then 1 hour later, you feel like you're a 90-year-old. It's like, you got to undo all of it. So a lot of stretching is involved, a lot of postural exercises are involved. And all of that comes in with patient education and teaching them these little exercises that they can do throughout the entire day.
Someone asked, what got you into physical therapy? And they said, you're awesome.
Oh, cool. Thank you. What got me into physical therapy is essentially I found it to be a combination of a lot of my interests. As a student that was studying engineering, I really am a big fan of structure and how one thing affects another and building from the foundation up and how to correct one thing to kind of improve everything else. And so putting that with the fact that I wanted a lot more human interaction that I wasn't getting through engineering, I put it with patient education and patient care, and I was able to come up with physical therapy because I was in physical therapy as a high schooler. And so I kind of just went back to that memory and I remember thinking that was pretty cool. So I ended up just shadowing and then I changed my major and I ended up with a job and here we are.
What is your advice for people who sit for prolonged periods of time?
Who sit for prolonged periods of time.
Yes.
So again, with studying, it's really about drawing shoulder blades together. It's about making sure you're pushing your chest up. A lot of people really sink in here, which is going to cause thoracic stiffness, so mid-back stiffness, as well as neck pain, because you're going to be twisting your neck in a funky way just to be able to look forward. So it's about pulling the shoulder blades together, pushing the chest forward, keeping the core really tight. The core tight doesn't mean you need to be sucking in so hard that you can't breathe or that you're hindered in any way. It's just enough to really engage the deepest level of your core, being able to support your low back, making sure you're not sitting. I am horrible at this. I always have a leg up on the chair as I'm sitting, which is always going to throw my pelvis off. It's going to unbalance everything. So it's making sure your feet are in front of you, your feet are flat, trying not to cross your legs if you're sitting for too long, making sure you're getting up and taking breaks. Walking, even if it's just for a minute every 1 hour, is super important just to keep blood flowing and keep things moving so you're not just forcing things in one position for so long.
Awesome. Does anyone else have any other questions? Okay, can you kind of talk about like what your life as a PT student looks like what your everyday life looks like with regards to studying and going to work?
My everyday life consists of studying every single day. I don't think during the semester I've ever had a day where I don't do some kind of homework or studying, just because it's a huge workload. And compared to undergrad, I definitely didn't really consider how big of a transition it was going to be. So it's making sure that you make time for studying and making sure that you enjoy it enough to not hate the fact that you're studying. So I do work and I am a full-time student, but during this past semester, I wasn't able to work so much because I was in class 8 to 5, 5 days a week. And one of the classes ended mid-semester, so I was able to go back to work. So a lot of it is going to class, eating in the car on my way to work, working, going home, and studying. So it's really important. And I'm sure a lot of people will say this through just about any medical field or any grad school in general, is making sure you have a really good support system with your peers. And so as a small group, we really get to know each other really well. So we're able to kind of read each other. And if someone's having an off day, it's helping them, making sure they get the material. So it's just study, work, and I have forced myself to make time for friends and family and getting out because you'll drive yourself crazy.
Do you have any advice on efficient study strategies?
I've always been a massive proponent of flashcards, and I think I could be a 60-year-old taking continued ed classes and I will still make flashcards because I find them very helpful for anything that is just memorization based, because that is not my strong suit. I'm writing it down, I am testing myself, I'm having other people test me always, and it's also just studying as you go. One of the biggest things is you can't just wait for 2, 3 days before the exam, and that's something I did my entire life. And then in PT school, I realized I have to study the material as I get it. You can't just put it off because you'll end up with an insane amount of work to do. So it's studying as you go, making sure you're doing little bits and breaking it up in a way that doesn't overwhelm you. So just as a person, I can't study at night. So past 8 o'clock on just about any day, even if I have an exam the next day, I put everything away and I call it good. I never study past that, never do homework past that. So make time for yourself so you don't go crazy and you don't get burnt out, but also make sure that you're getting ahead of your work in advance. Anything that's hands-on, I don't imagine there's much in undergrad that's too hands-on, but as you kind of progress through grad school in just about any health field, it's making sure you practice on anyone and everyone you can, every body shape you possibly can, because what I feel on one shoulder, I'm going to feel completely different on another shoulder. So I get anyone I can and I just feel it always.
What is your least favorite thing about PT besides the studying?
Least favorite thing about PT besides studying, I don't actually have to deal with it yet, but one day, hopefully fingers crossed, as a PT, there's a lot of paperwork that's involved with every single patient that you see every single day. After each patient and each treatment, you do have to fill out a note, and day in and day out, I'm hearing the physical therapist complain about notes. It doesn't take too long. It's just tedious because if for whatever reason insurances have to look into your documentation, you have to make sure that you document everything. So it's tedious work. It's not exactly what everyone signs up for when they want to be a physical therapist, but it's part of it. I don't know. I guess we'll see if I hate it once we get there.
Does anyone have any other questions? Okay, we can wrap up then. So thank you so much for this incredible and insightful session. I really enjoyed how interactive and encouraging you were, and I hope to have a session with you again in the future. If you would like to post any of your social media handles or links to any businesses in our chat, please feel free to do so. To our Wayne State University students, please make sure you complete the Google survey posted in our Zoom chat summarizing the session to obtain your shadow hours. And thank you all, and I hope you have a great night.
Thank you guys for tuning in. I really appreciate it.